Welcome back to the Syndromic Insights, the podcast brought to you by the World Society for Pediatric Infectious Diseases. We are your hosts, Dr. Alicia Chang
and Dr. Linny Phuong. In today's episode, we're exploring how we can utilize syndromic testing to help predict and prevent future health threats. The COVID-19 pandemic showed us all how important collaboration and communication is between infectious diseases experts and regional and international public health authorities. But what lessons have we learnt from this, and can syndromic testing help?
To explore this issue, I hosted a fantastic panel with Professor Nicolette Duplessis and Dr. Kevin Messacar, who shared their expertise and reflected on the issue. Before we get to the interview, let us introduce our guests to our listeners. Professor Nicolette Duplessis is an associate professor, HCU in Pediatric Infectious Diseases at the University of Pretoria. She is the president of the Federation of Infectious Diseases Societies of Southern Africa. Her research interests include diagnosis and management of HIV, tuberculosis, vaccine-preventable diseases, disease surveillance, and antimicrobial stewardship.
Dr. Kevin Messacar is an associate professor of pediatric infectious diseases at the University of Colorado Anschutz Medical Campus. He's also a practicing pediatric infectious diseases consultant at the Children's Hospital Colorado. Dr. Messacar's research seeks to improve diagnosis, management, and prevention of central nervous system infections, including meningitis, encephalitis, and myelitis, with a focus on enteroviruses and other emerging infectious diseases.
I had a great conversation with Nicolette and Kevin. I'm really excited for you to hear it, Linny.
Great, let's go check out their conversation.
We're privileged to have you both with us today.
Thank you, Alicia, and thank you for sharing the platform, Kevin.
Thanks so much for having us. Looking forward to chatting.
Before we dive into the details, could you both contextualize your work and the health systems you primarily work in, and what our audience should bear in mind during this discussion? Let's start with you, Nicolette.
All right, thank you, Alicia. So I work in South Africa, in a province called Gauteng, which is probably the main sort of economical province. And I work in a big academic hospital. So keep in mind that about 85 or 90% of our healthcare system is public or a national healthcare system. And the main focus is primary healthcare, which are clinic-based, with referral centers then becoming more centralized into bigger hospitals, tertiary and quaternary hospitals, and those hospitals are usually then connected to a university. So this is in one of these centers that I work. We have very limited diagnostic capabilities on the local clinic level. And then, of course, in an academic hospital, we have access to more diagnostics through our National Institute of Communicable Diseases, or the NICD. And NICD is based in Johannesburg. And so we can do some testing on a local level, otherwise regional. And again, most of the more comprehensive testing are done at their lab in Johannesburg. So very limited, but we are lucky to have a functioning healthcare system in an African setting. So to remind you, South Africa is actually known as a high middle income country, and there's about 8 countries in Africa that are high middle income that have got some of these facilities available. It's unusual for Africa. Then we've got 10 or 15% of the population that can access private healthcare, and I think you'll be familiar with this through medical aid or self-funded or insurance. And there are numerous laboratories that serve the private healthcare system. Unfortunately, they've got access to much broader diagnostics, but they don't actually share that data set easily with the national data set. So we've got these 2 data sets, the biggest one where we do research in the public setting, and then a much smaller but probably more comprehensive private setting.
Thank you, Linny Nicolette. That was wonderful. Now, I guess it's your turn, Kevin.
Thanks, Alicia. I am located outside of Denver in Colorado in the US. I work at a quaternary care system at Children's Hospital Colorado. That's a major referral system for the 5-state region that surrounds us. So we get a lot of patients referred in who are mystery patients that they can't figure out a diagnosis or have severe disease, in addition to routine general pediatric infectious disease. So we see a wide spectrum of cases on the clinical inpatient service. We have a wonderful microbiology lab in-house that's dedicated to our children's hospital, and they like to keep on the cutting edge of new and emerging technologies, including some of the molecular technologies. So we do have access to rapid multiplex PCR panels. And then there are a number of our faculty members who are really interested in diagnostic stewardship and how we learn how to implement kind of the newly emerging diagnostic technologies, be it next generation sequencing or pan-viral antibody testing. And so we are working on the research side on how to validate and implement some of those tests for clinical care. And in addition to the clinical testing and research testing, we also partner with our public health agencies, so our state health department and the CDC. And we have a number of projects looking at things like wastewater surveillance or doing more routine surveillance for emerging infections to help us prepare better for what's to come.
Thank you, Kevin. I guess it is wonderful to have you both because now our audience can see how different the settings of each one of you are, and how different is the way you work and the accessibility that you have to resources. So I think it's going to be a wonderful discussion. So let's start with you, Nicolette. So the first thing I want to ask you, when we're going to be centering about respiratory diseases, is how do you define syndromic testing for respiratory diseases, and how do you go about doing it in your setting?
Thank you, Alicia. So we know that syndromic testing refers to generally multiple pathogens that one can target with one test, and these are PCR-based testing or molecular testing, basically. And what you want to target is a group of patients that has got overlapping symptoms and signs, and so that refers to the syndrome. So you would have patients with similar symptoms and signs that suggest this is a respiratory type of syndrome, and you would do multiple testing and in one go have identified either the causative pathogens or co-pathogens, if you think someone is co-infected. So these are molecular panels, and they can include just viruses. So to give you an example, in our public sector, we have limited multiplex capability, and the panels that we use are mainly for our vaccine preventable causes, and so that would include influenza, RSV, that's at the moment not vaccine preventable, but as Kevin can also attest, this is coming soon, so watch the space, and SARS-CoV-2. So those are the three viruses in our sort of multiplex panel, and then we add pertussis testing to it. So those are the four sort of tests that we can do in our public sector to really look at breakthrough disease. Do we need to go and vaccinate a community? Fast forwarding to the private sector, we've got a much bigger array of multiplex testing there, but we use it for a different reason. And in private, it's really to inform the patient itself, not necessarily translating to surveillance in the community, or we don't activate sort of the community, management of it. It really is a self for the patient to understand what the cause is for the specific symptoms and signs.
That's wonderful. I think that in Guatemala, we work sort of the same way you guys work in South Africa. We do have a limited access to respiratory panels. And recently, they just got like a like a panel that is extended, that has more viruses and bacteria. We are having a lot of issues with pertussis, which, I mean, we kind of were expecting because we have very low vaccine coverage. I mean, since I believe the pandemic, or even a little bit before that. So we need to be very selective, I suppose. And I think it's hard for the clinician to know when to get the big panel versus the small panel if you have access to it. So is there any pearls or keys or advice that you can give in that regard?
So I think it's difficult to really understand what's happening in the community and give advice or go for revaccination campaigns or really have an impact if we have such limited testing in inpatients. And if we have even financial constraints, we would really test only patients that need high care or ICU type care. And so you can really report back on the causative agent, whether it be influenza or COVID-19 that we're both struggling with this time of the year in South Africa in severely ill patients. And so you can look at maybe infection control or cohorting within an ICU in a hospital. But I don't think that always can translate to what's happening in the community with less severe disease and with things like loss of work days for the parents because the children need to stay at home. They're not necessarily hospitalized. So with the constraints that you also have and that I've got, I think it's really difficult to translate in a community, really in impacting our community. I think that the only thing going forward is to maybe have easy, accessible point of care testing within the community. But our financial constraint just doesn't allow us to have multiplex testing. If we see that there's a red flag, and I think we can talk about that with Kevin even in the future, if there are some red flags nationally or internationally, then I think to try and be as part of research as quickly as you can and to communicate and collaborate with people that have got access to multiplex PCR is probably the best way for us going forward. Really important to collaborate, and then sometimes we can get access to further testing within the sort of financial constraints that we work in.
And I'll just add on to what Nicolette said there. In the regular setting where you're not in the midst of an outbreak, at least coming from a area where we do have access to most of the multiplex panels you're talking about, we actually found the major challenge was overuse. So everybody had access to it. Parents like to know the name of the virus their child had. Providers like to be able to have an answer. But really, when we looked at resource utilization and the amount of money that was going to spending on these multiplex panels and the lack of clinical impact, where in situations like a child with bronchiolitis, it doesn't matter if it's rhinovirus or RSV on the patient-specific level, we actually had huge improvement projects driven actually by our hospitalists. We had a campaign called Rest is Best for bronchiolitics, where it was recommended we didn't test the average child of bronchiolitis age who came in with a classic presentation. And the better part of valor was to support that patient with supportive care, oxygen, suctioning, but limit testing and non-evidence-based interventions like steroids and albuterol. So this was a very successful campaign. And then over time, we saw the pandemic come and everything changed, where we were wanting to test every patient that came in the door, mostly for a SARS-CoV-2 target. But it was very sad to see the backtracking that happened with all this diagnostic stewardship work during the pandemic. And now we're in a phase of trying to get back to a state of normalcy. We still are testing every patient that comes into our hospital for infection control purposes. So hospitalized children, as Nicolette described, get a RSV, flu, COVID, PCR. But we're trying to limit it to that more targeted panel and really save the more extended panel for our patients in the ICU, our mystery patients that need a diagnosis, but not test every patient that comes in the door with these high cost panels.
I think that my next question, Nicolette, is: are there any limitations to syndromic testing in children? And how is this syndromic testing different in children versus adults? What should we remember as clinicians in terms of clinical presentation, kids versus adults?
Thank you, Alicia. So I'm going to start just with generalized principles, and I'm going to ask Kevin to finish because he's got much more experience in daily use of them. But as a pediatrician and teaching our pre-grads and post-grads, I think our favorite thing, and Kevin will attest, is to say that children are not small adults. And what counts for an adult does not necessarily count for a child. And so the advantages of syndromic testing is you have the capability of identifying multiple pathogens all at once. But the samples can be a problem in children. We now are specifically talking about respiratory samples. To take a swab might not be that difficult in a child, but to try and get sputum in a young child is extremely difficult. And we all know with aerosolization, even during the pandemic, and trying to get induced sputum in children can be quite a challenge to the clinician and the physiotherapist and the parents. And from an infection point of view, you're now aerosolizing things. So really trying to get some of these samples. Kevin works a lot with meningitis. So to save that very gold last bit of CSF, you just are not going to get the same samples as you would in adult patients. And so trying to get the sampling from children could be a challenge. Then the type of pathogens, working in a low and middle income country is often different. We know the pathogens are different between children and adults. For example, finding a C. diff in a stool of an infant could just say colonization, where in an adult high-risk patient, of course, you're going to, react to that. So one needs to be aware that many of these panels were validated first in developed countries in adults and not necessarily what we want to know in a developing country looking at a pediatric population. And then I think one of the important lessons that the pandemic taught us is that children can present with different symptoms and signs and could fall into a different syndromic panel if you just go with the clear panels. During the pandemic, we had more children admitted with gastroenteritis and with febrile convulsions that had subsequently tested positive for SARS-CoV-2. And so if you're going to follow your clear syndromic testing, you would have done a gastro panel on a COVID child, or a CSF sample in a febrile young child with a febrile convulsion, where actually one should be looking at pediatric protocols and then in which panel are you going to, or which group of tests are you going to focus on. And so these are just sort of the highlights for me that you have to consider when doing syndromic testing in children. But I think Kevin can give us some more pearls of wisdom because you use it almost daily.
Sure, and I'll start with some kind of big picture caveats to the syndromic molecular tests. First and foremost, from a diagnostic reasoning standpoint, I think we're all taught think about your pretest probability and then send a test that can confirm or deny that possibility. When you think about syndromic panels, it really throws that out the window because you're getting testing for a lot of things that perhaps you didn't want a result for. So you have to put those into context. Say you see a kid with prolonged fever that has red eyes, but also a red throat and some discharge from the eyes, and you want to look for adenovirus. Well, really the only test we have to run for that is a multiplex panel now. And say that picks up something like a rhinovirus. You have to say, yeah, I sent that panel looking for adenovirus, but the kid had a rhinovirus. Is that really the cause of this, or could this be a case of Kawasaki disease? So I think really using our diagnostic reasoning skills and saying, hey, I never really thought this kid had rhinovirus to begin with. Even though we detected it, it's probably not what this kid had. And I think some important kind of caveats that go along with molecular testing are that we're looking for the genes, not for active viral replicating disease. And so we know that there are a lot of viruses that shed for prolonged periods of time, so that maybe the kid had a cold 2 weeks ago and is still shedding rhinovirus. We also know there are asymptomatic infections that can shed virus, especially with rhinovirus B. That's very common. There are also other settings in which the other panels can detect reactivating viruses, things like CMV, where really sick kids can reactivate their herpes viruses, and then even things like chromosomally integrated viruses like human herpes virus 6 or HHV6, which is on one of the spinal fluid panels, has caused us a lot of trouble because it gets detected in about 1% of the population at baseline, just because it's in every one of their genes chromosomally integrated. So I think we can't turn off our brains and just, say we're going to use this broad testing and it's going to tell us what's going on. I don't think we're ever going to be out of a job. It really takes that clinical context, that diagnostic reasoning that ID doctors are so good at bringing to the table. So I do think this can be a bit overwhelming for general practitioners in that the diagnostic technologies are advancing at a rate that's really hard to keep up with if you're in general practice and you see infectious disease and everything else. So I do think one of our roles as infectious disease specialists is to help orient our providers to these new tests as they come out in the clinical setting, and then help them to interpret them in the clinical context, because I don't think it's as easy as getting the test result and knowing that that's what your patient has.
It's exactly right. You get those panels, you get a lot of viruses and bacteria, and you will always need to go back to your clinical assessment and interpret those results in the light of that assessment. And just ask yourself as a physician, as a clinician, well, this result makes sense in the setting of this patient. I mean, according to what I found, what I asked to him and the information I got, I think is very important, and that's when really I think a lot of physicians and practitioners are gonna need our guidance, and that's why we're here for. And this podcast is really directed to everyone that is working in health. So I hope it can also be helpful to other practitioners outside of the infectious disease world. Anyway, so let's keep on going. This is getting super interesting. So, Nicolette, do you think that there are any ethical considerations that we should take into account when we are doing syndromic testing? And how do we balance this diagnostic stewardship with other factors?
Thank you, Alicia. It's a very good question. I'm going to start with the ethical consideration to remind the listeners that we all know that access is limited, especially in our most vulnerable population. And then from an ethical point of view, this is something that clinicians should always be aware of. On that, I also want to, just put some context in South African context, that many of these panels do not contain the opportunistic infectious pathogens that we desperately need to rule out in a child living with HIV. It doesn't contain TB, doesn't contain, pneumocystis, or, some of these real infections that you can make a difference with early intervention. And then I'm not even talking about the rest of Africa, where malaria is obviously an ongoing problem. So I think the first thing is I want to reiterate what we said previously in terms of, I think, non-maleficence, first do no harm. I think that's one of our most important ethical principles. And we know that the more we can test things, the more results we find, but the less we know what to do with them. And so from an ethical standpoint, if we do not educate our young doctors, educate the public, and educate people in terms of what are these tests useful for and what do they mean? If you get a result, what does it mean? I don't think we are doing the community a favor. I remember stories in private where I would get patients that follows up with me and they would say, "Doctor, I remember I looked at the results and my child had double pneumonia." Now, I can't remember reading about double pneumonia in any of our infectious diseases books, But as Kevin have said, they would find a rhinovirus and something else, and these parents decided, no, the child was double sick this time. So education there is an extremely important for the parents and for especially the junior doctors. I think you have a sense of, power the more you can test and the more of these tests you can use. But on a primary level, how to really translate that into, patient care, and sort of that what if factor. What are you going to do with the results if you get it? So I absolutely agree with Kevin that you have to have this pre-testing probability of what am I going to do if I get a positive result, and how is it going to change my management and the impact on my patient, and then of course an ethical point of view, the biggest community. And so with that, I think the ethical principle of benefit comes in, is where can I actually make the biggest change? Do I just want to know, is it a vaccine preventable disease? Do I want to look at surveillance in terms of a new outbreak? Those could be really important questions. And therefore, one can actually then say, right, we need to do more testing, or we need to employ multiplex testing because I need these results and it's going to change the way I manage my community within the next few weeks. So I think that the last thing in terms of ethical consideration, and I think Kevin is going to talk about diagnostic stewardship, so I'm going to leave it with him because an important ethical consideration in terms of the benefit and the non-maleficence is to, look at stewardship, diagnostic stewardship, laboratory stewardship, antimicrobial stewardship, and to not overdiagnose and overuse the resources that we've got. But I'm just going to leave you with this, that I think teaching our young doctors in a big academic hospital, one of my senior colleagues used to say, it's like teaching someone to play golf on a putt-putt field. It's just not exactly the same, And so we also have a responsibility to teach our juniors what it's really out there, and how can you utilize and should you utilize the testing that Kevin, for example, has got access to on a daily basis. Should you be utilizing it in an outpatient basis, at the clinic, and how is it really going to inform your management there versus the facilities that we've got in a research setting or an inpatient setting. And I think that's all of our responsibility.
Yeah, I love this topic, and I love your take on it, Nicolette, because I think a lot of people see diagnostic stewardship and then the value of surveillance as kind of contradictory to each other, which I don't exactly agree with. I do think that there is some synergy there, but I do ethically think it's really important that we differentiate what we're doing for clinical care, what we're doing for public health surveillance, and what we're doing for research, because though there can be some interplay there, they should be kind of thought of separately. And in the first ethical principle, I think, Alicia, you hit the nail on the head really well. We should not be testing patients and giving them the passed on cost of testing if it's not going to influence their clinical care. So just like Nicolette said, before you send that test, how am I going to interpret this result? How is it going to change their care? And if it's just giving a name to what they have and you're going to manage them the same way, regardless of what virus they have, you probably shouldn't be sending that test. And certainly if your thought is, I just want to know what's going around, ethically to me, that shouldn't be passed on to the patient. That should be in the public health side of things. This question often gets posed to me because we are very interested in using a lot of the larger data sets from the clinical testing, because it's now real-time data looking for lots of viruses at once from people all throughout the country and throughout the world. And I'll share some of those resources before the end of the podcast, but now you can go on publicly facing websites and see the percent positivity of the various respiratory viruses going through your region. If you participate in some of these companies' programs, they will feed that data back to you so that you can say, out of my center, out of my lab, this percent of kids have RSV right now. And I think that actually helps with diagnostic stewardship, because then you can, instead of testing that next kid that comes in, say, 80% of kids right now presenting with this presentation have RSV, and this kid looks just like bronchiolitis. I can manage them presumptively. So I think there is some interplay there, but I would caution people that we shouldn't be doing testing for surveillance purposes and passing the cost on to patients. I do think we should be making best use of that data, and always the tension between diagnostic stewardship and public health surveillance. My answer is always, even with the most aggressive active diagnostic stewardship programs to try to limit testing, we still get so much data generated. There's still so much testing that goes on that I think we can use a lot of that. The other ethical principle I wanted to bring in is on the research side. I'm really interested in how these new technologies enter the clinical market for clinical care. And it's a very different pathway than a drug that hits the market. Typically, you have to go after an indication, you have to do a clinical trial, you have to show clinical benefit. We're all familiar with the phases of drug trials and vaccine trials. Diagnostics are a little different. They basically have to show in the lab that the test does what it purports to do. It finds the targets that it says it's going to find. But what we're finding as these technologies go from like a pathogen-specific test that, an HSV finds HSV if it's there, to a panel that it can find all the targets on the panel, to now these unbiased tests like next-generation sequencing that can look for everything, every DNA and RNA pathogen within a sample, is that we don't really know how to use them for clinical care. They haven't gone after a specific indication, so you're left with this test that can look for everything, but you actually don't know clinical data on when it's useful. You don't know when it's cost effective. So I think the onus is actually on these companies and on us as clinical researchers to do better clinical research up front before these technologies hit the market and everyone wants to use them, but doesn't know what context to use them. And oftentimes I think they're overused or in situations where they're not very useful because we're trying to figure it out on the fly. So it's very difficult to set up structured clinical trials for diagnostics, but I think as we get more and more advanced in unbiased in the technologies we use, it's even more important that we do targeted trials for particular interventions. Does this work for culture negative endocarditis, to do next-gen sequencing of blood and try to find those pathogens we can't culture? That's a great research question to me. But what we find instead in the literature is all these observational cohort trials of people using these technologies in whatever case, 2 weeks after they can't figure it out. And of course, the data is terrible and it doesn't show a lot of impact. And it's probably because we're not using the test to the best ability we can and not having good implementation strategies. So I do think there are a lot of ethics involved in how we use these syndromic and even unbiased tests for clinical care.
Kevin, and I think that, expanding a little bit on how we should consider all of the ethics involved in testing our patients. Here in Guatemala, we have seen a lot of changes in the seasonality of the viruses. So sometimes physicians, they tell us, well, we need to test for everything because now we don't know when is RSV season, when is influenza season, because it seems like it is spreading throughout the year. So how do you handle this? And if you have any observations about this change of the seasonality of the viruses also in your region?
I think this is such an interesting phenomenon. We basically had the biggest natural experiment in our lifetime that I think has happened if you read the history books during other pandemics, when we put all these non-pharmaceutical interventions in play to target the pandemic pathogen. Obviously, they work for the other pathogens that are spread in similar mechanisms. So we found that not only did, all the NPIs for SARS-CoV-2 work for that, but they also worked for RSV, influenza, and many of the other respiratory viruses. So I think as our adult colleagues were really getting slammed with COVID cases in the thick of the pandemic, all of us on the pediatric side were saying, what is going on? We're so quiet. We're not seeing our normal RSV, flu in those seasons. And I got really interested in this, looking at some of that syndromic trend data from the clinical testing platforms that basically showed everything plummeted when we put lockdown measures in place in the US, and just wondering what was going to happen when they returned. And so we worked with some mathematical modeling groups that were really interested in this type of modeling called SIR modeling. Very simple. You go from susceptible population to getting infected and then being recovered and having some level of immunity. And basically what they modeled over time is, as we didn't see these respiratory pathogens circulating, the normal kind of 0 to 2-year-old kids that would have had their first RSV bronchiolitis season, never saw the virus. Mothers had less exposure and lower antibody levels. And the suggestion was when they came back, they were going to come back in unusual ways. There are pressures epidemiologically that population immunity puts on the pathogens that drives them towards seasonality being a major driver. And in temporal regions, it's, dew point temperature and other climate factors that give us the seasonality of enteroviruses and RSV. But when you take away that population level immunity pressure, those seasonal pressures kind of have less impact. And so you can start to see these things come out of season, which, we got so used to knowing when RSV would come and influenza would come. And pediatrics is so seasonal. We staff up during our respiratory season. We staff down in between. We really got hit so hard in 2022. We had that unusual RSV season that was a little early in 2021, but it really was 2022. It started with the rhinoviruses, then the parechoviruses, then enterovirus 68, then RSV, then flu, and COVID was in the mix the whole time. And hospitals in the US had triage tents out front at altitude here in Denver. We couldn't keep up with the amount of patients who needed, oxygen and support. So we were expanding into other areas of our hospital for inpatients. It was really an unprecedented setting. And what we've seen over time is that slowly, I think we're rocking back to a more normal seasonality and more normal patterns over the following seasons in 2023 and hopefully this year in 2024. But your questions as far as testing go, I do think it's an interesting question because I do think it's helpful to know what's going on and what's going around. But I will say in these settings where we do have access to these panels, even though our algorithms point and refer providers to only ordering them in the most severe patients, ICU level patients, we get enough testing and enough of that data fed back to us that we do have a really good idea of what's going around. So I will say, I think it is helpful to have some idea and some sense of what's going through your area. We've tried to take that a step further and do some predictive modeling to know what the next season is going to look like. Some of that is by the pathogen testing. Some is by we're doing serosurveillance. We're drawing blood for research purposes and research projects to know the levels of seroprevalence amongst younger kids, 0 to 10 years of age. That gives us a better sense of what the next respiratory season is going to look like. So I think all of that can feed into preparedness efforts. And obviously, I think it's difficult to say that would be best use of resources in other places where those tests are very expensive. But I will say, I think it's good to try to make the best use of the data you generate when those tests are being run. And so trying to have some system in which your lab can process and feed back that data to you in terms of what you're seeing and what's going around your area.
Thank you, Kevin. Now that we have lived through a pandemic, everybody is kind of expecting that maybe another pandemic may happen. And the respiratory viruses seem to be at the spotlight of the pandemics. I mean, it seems like they are most likely to cause trouble in the future. So I wanted to ask both of you a little piece of advice in terms of how do you react to red flags in terms of respiratory viruses given by the WHO or the CDC or any other agency that actually is monitoring infectious diseases or is doing surveillance in your regions? Do you talk to your staff first, your team? How do you go about these maybe alerts that may happen? I mean, time to time. Right now, we are increasing our cases of COVID here in Guatemala. So everybody's asking me. And then after you talk to us a little bit about how to react to these red flags, maybe if you detect that there's some way we can improve the communication in between us and those agencies, that would be awesome if you can comment a little bit about it. So let's start with you, Nicolette.
Thanks, Alicia. So I think that what we learned from the previous pandemic is that usually the first red flag or the first signs are from the more developed countries because there are just more testing. And so when we heard about the first testing, obviously our national lab, which has got some surveillance site, got hold of the specific viral characteristics and started doing very limited testing. And at that stage in South Africa, I think our first response is sort of a delayed response. I think unfortunately we have, or fortunately we have, social media at the moment. So should actually say the main response was an emotional community response, right? We had no evidence in South Africa. We had no cases until the start of March, but everybody was up in arms. And I suppose in a sense, because the community has now also got access to these red flags from the CDC and the WHO, through social media, through the internet, through television, they do then tend to come to their general practitioners and to the centers if they feel ill. And so I suppose the good thing where I am is that it did increase testing, and through that, once we could actually test for the virus, at least we had a slow sort of input on samples. On that note, from an ID physician point of view, we then sit back, and I remember talking to the staff and saying, take that history, because in any new virus, in any new illness, we follow the ID steps, which is exposure, infection, and then disease. And so you have to go back and at least say, take a proper exposure history. And the first case of SARS-CoV-2 in South Africa was after the patient gave a history of recent travel to Europe. And so we do reiterate, again, you don't have to necessarily test someone that's been in the house for 2 months, and now is coughing. But go back to that history and look for that specific exposure to what could be a new pathogen or suspected outbreak. So then we started, I think, improving in-hospital cohorting. So we don't necessarily know what we were dealing with at that stage. We don't have access to all the testing. But if we know there's something out there, some pattern that's showing us we're talking about respiratory illness, that there is a possible outbreak or a possible new international outbreak of a respiratory pathogen, we just strengthen our cohort systems and infection control systems. For me, that's important on that stage. If the staff has not been vaccinated to vaccine preventable viral diseases, they should really get vaccinated. There I'm really quite strict. First principle for me is you have to be safe. You can't look after patients if you don't try and be safe. So we really then, because we don't necessarily then have the diagnostics to know what we're dealing with, but we talk about safety for the staff, making sure your vaccines are up to date. You're wearing a mask, you're going home and not infecting your loved ones. So really infection control, infection prevention control, cohorting. That's what we do in hospital. I think we have very limited efforts until we really know what we're dealing with and what is the R naught of an infection and how infectious it is and who spreads it, who's more infectious, adults versus children. Until we have that information, it's difficult for us where I'm working to really have a community, management or a protocol. So I think that's more or less how we manage it. So basically in the dark, but going back to proper history and proper infection measurements. That's about it in terms of red flags. I think maybe if I can add is to remember that our population is different. And so the way they present when we are getting these sort of signals from an international point of view, you have different symptoms and different presentations, especially in your immunocompromised patients. So our children living with HIV certainly presented much differently, and they still do. With some of our respiratory syndromes, they have more incidences of apnea, for example, or very mild distress, or and then another group becomes very hypoxic. So because we've got an immunocompromised group, we've got a high rate of malnutrition in our public sector, these children present frequently with some more subtle signs maybe, or different symptom and sign set. that does make it difficult for us to understand if this is now part of, the suspected outbreak, or if it's something else that we're dealing with. And so that's an additional challenge, I think, in an African sort of context, and one just needs to keep in mind.
I think it's very important that you said that, because we all have different contexts, and this is going to be super helpful for regions in which your context is very similar to theirs. So thank you for that, Nicolette. How about you, Kevin? Do you have any comments on how do you react to red flags from WHO or CDC?
Yeah, I'd just like to add that every red flag got raised typically by an astute clinician at some point. So to really value the input from the providers around you that are saying, hey, I'm seeing something unusual, this is atypical. Typically the first steps, we've talked a lot about syndromic testing, like using tests that have a lot of targets, but syndromic surveillance can be really useful in the initial outbreak investigation. So coming up with a case definition of what you're trying to count or what you're seeing that's unusual, going back and getting some historical data to say, hey, yeah, this is something out of the norm of what we've seen in the past. And then typically moving to the clinically available diagnostics. And sometimes it's just a typical pathogen that's coming back in an unusual way. A recent example was post-pandemic. First, we heard from China in 2021, new cases of mystery pneumonia, and then Europe. And it ended up when they did additional testing, it was a mycoplasma outbreak having returned post-pandemic. So sometimes it's a known pathogen just coming back in unusual patterns. But when you do get negative testing on that testing when it comes back, it is worth talking to your public health agencies and going to that next step of unbiased technologies. I think our sequencing technologies are really robust now at finding either novel pathogens or closely related pathogens that are newly emerging. Some recent examples of this, some colleagues in Kansas City in 2014, they actually had some visitors from the CDC investigating a parechovirus outbreak in their NICU when they heard from their ED providers, we're seeing a ton of wheezing kids. We're like being overwhelmed, and this is not a usual season for us. And they took it seriously, and they looked at their volumes. They said this is unusual, and they sent the samples to the CDC, and they sequenced enterovirus D68, which was kind of newly reemerging respiratory virus at the time. Again, a red flag that was raised by astute clinicians. We followed that up in Colorado with noticing kids that looked like polio during the same outbreak and made a link between this emerging respiratory virus and what we now call acute flaccid myelitis. And all of that was really fed into by initial observations by astute clinicians and the use of diagnostics. I totally agree with Nicolette that the availability of diagnostics for emerging infections is really essential. We're seeing this with H5N1, where we have an outbreak currently in the US in our cattle, and we are starting to see spillover in the agricultural sector, including here in Colorado. And I think it's really important, like if we see kids who have, conjunctivitis or influenza-like illness and they test positive for an influenza target, but we can't type that on our commercial platforms, we are supposed to send that off to our state to test for H5N1 to know where it's going around. And there's still probably a lot of under-testing going on. And that's where I think we can start to implement serologic testing. I think as emerging pathogens come out, yes, I totally agree with Nicolette. Focus on the targeted population first, those with risk factors, those that meet the case definition. But we probably, with that, are finding the tip of the iceberg. And on the public health level, to know how widespread emerging infections are, it really takes looking at those patients that could have had it in the past that are seropositive or could have been asymptomatic, and really knowing just how much it's spreading in your community. And I think we're seeing that in real time in the US with H5N1, which is really scary.
Thank you, Kevin. My last question, before you guys give us some final thoughts, will be: Do you think? Do you feel? Do you know if in the world stage, like all the scientific institutions and and maybe the World Health Organization. Do you think that we are getting ready? Do you think that next time a pandemic happens, we'll probably be in a better shape? Do you know of any mechanisms that maybe they have implemented to do a better job than what we did last time? If you don't know of anything, it's fine as well. But I
I,
just I just have to know. I just had to ask, actually.
I'll give you my optimist and pessimist side of things. I think the technology is there. We are so advanced on our diagnostics about doing surveillance, doing sequencing, finding new pathogens, the creation of vaccines and mRNA technology, and how quickly that came about as far as the response is just totally incredible. I think the science is there, the research is there, the technology is there. The inequities as far as the world response about making vaccines available to people, the political response in terms of the public's appetite to comply with MPIs and to get vaccinated, and just the general ability of the world to work together is what really disheartens me. I hope that we can learn lessons from the things that went right and the things that went wrong from the pandemic. But I think it's less so the science that we need to work on and more so the political and inequity side of things that we really need help on to do better the next time.
I absolutely agree with Kevin, and I think that in terms of sort of international readiness, we all know about the Pathogen X program, and as Kevin has said, everything is sort of ready for the next pathogen. What I saw is quite an improvement is that, and maybe Kevin can give his sort of experience with this, but we as the ID community has really grown together and has got this One Health focus going forward, much more post-pandemic than pre-pandemic, and we even on One Health panels now that we were not before the pandemic to try and cross over between, is it a zoonosis, and as he's alluded to H5N1, what do we see in the animals? What do we see in the animal handlers, and how does it translate to possible next pathogens that we could see in our community? So I think that I've certainly in my area seen as an improvement that we work close together with other communities. We're not just ID physicians sitting here in a big hospital, but we need to work together to understand what's happening in terms of animal health and contact and then the community health. So I think that has improved, but of course, we've all said this, the lack of testing in the most vulnerable populations, I think, might lead to a bit of a lag in identifying the next pathogen X if we're not all there and we're all enthusiastic. And it literally means we all know the story, right? One physician or interested party, even a pharmacist or a lab technician, finding more cases or interesting cases or not finding what you expect to find in samples, and then sort of alerting the authorities. And I don't know if that's really going to change. I think that's how we're going to find the next pathogen probably as well, right? What we certainly have seen locally is that there's a lot more talk. We've got a lot more WhatsApp groups that I need to keep quiet during the day. We've got much more junior doctors consulting us now, asking about, do we think this rash is a problem? Does it fit in with what we think? So at least from a positive local point of view, there's lots more conversation. Now, whether that can cause more drama than solutions sometimes, we all know social media and WhatsApp groups, but at least it has actually increased, I think, maybe people's interest in what's new or what's curious out there, what's different from what we expect. And so at least I see that as a positive moving forward. And most of us has become, especially in an African setting, I think electronic, and at least we have access now to electronic results. That has been a good thing post-COVID. We've got an international or national hotline which you can phone to get advice. So I think it has strengthened some of the communication channels in a less developed country. And it has strengthened communication to and from these centralized laboratories, but it is still quite limited. So I can still see a single lab tech or a ED physician, alerting the authorities to unusual cases, probably of the next pathogen X.
Nicolette, I couldn't agree more about your comments on the solidarity and collaboration in the PEDS ID community. And I just wanted to speak to the kind of importance of the future of our field. I'm obviously very biased. I've always said, the heart's always going to have 4 chambers and cardiology is not going to change that much, whereas infectious disease every year throws new challenges, is new and different and exciting. And I think we've really staked our claim through the pandemic, all being pulled in different directions and filling different roles outside of just our clinical care, as far as, public health, getting society back to normal, responding to this huge event in the history of the world. But what worries me is we saw a kind of post-pandemic bump where people were really interested in the field, and we've really seen that ebb and flow in terms of now it's retracting again, and our pipeline is really thin and drying up in the US, and less people are going into infectious disease, both adult and pediatrics. Our fellowship positions aren't filling. So I really think it's important for us as a field to think about how we work forward to getting people interested in our field, making sure we're compensated effectively, so that we can attract the best talent, because we have the most interesting field. It's incredibly important, not just to healthcare, but to society as well. And I think we have some work to do as far as practitioners and how to kind of stake our claim in the field of medicine so that we draw the best people in.
I think it is very important what you just said, Kevin. We are having fewer and fewer persons getting into ID also in Guatemala. I'm not sure what the reason is, but certainly we're trying to get everybody excited, get to have networks so that people get involved in the field and feel like there's a very big and strong safety net that they can hold on to the rest of the colleagues, and that as you said, this field is very exciting, always changing, and that I hope that this podcast also helps a little to get people excited. I am excited. I'm always happy to talk about my field, and I feel that inspirations from you and Nicolette as well. So I feel like people hopefully will respond to us, to our enthusiasm. So finally, any thoughts, anything, any last few words you guys want to tell our audience? And if you have any research or work that we can follow on, please let us know about your social networks or websites. We will be very happy to post them in the podcast for our listeners.
Thanks, Alicia. Maybe start and just say that thank you for this fantastic opportunity, and for everybody working in resource-constrained areas. We like to focus on the fact that we have got constrained resources instead of focusing on the richness of knowledge and experience that we actually have, and really for the young sort of career doctors out there to know that knowledge is power, and you can reach out. We are maybe not as many in low and middle income countries, but we are here. So as the Federation for Southern Africa, if you go to the FITSA website, you can contact us, you can chat with us, and really try and collaborate and tell us your stories, and just try and build up not just nationally, but internationally contacts and assistance, I suppose, and enthusiasm for not what we can't do in limited countries, but what we can do. and that's to share our knowledge and experience. And I think that goes sometimes much further than concentrating on, what one can't do in life. So the FITSA website is where all of these federations, amalgamation of pediatric and adult and the microbiologists come together. So people are more than welcome to look at our social media platforms and the website. Our NICD website has got a rich volume of information about the surveillance that we can and are busy with. Although it is limited, again, it's there, and one can use it, and use it to inform the way you treat and manage patients going forward in a limited setting. So the NICD has got a lovely website on specific ID topics and a rich sort of data of knowledge, especially in low and middle income countries, that the listeners should go and access. And for my research and to contact me, I suppose LinkedIn is probably the best, right?
Yeah.
To find me there and send me a hello, and we'll see what research we're busy with. And that's got links to the university and to FITSA, where you can read what we, not just me, but as a federation, are busy with, and where maybe people in other parts of Africa can link in with us. We've got a fellowship program where there are many African fellows that come down and train and then go back and take that knowledge with them. So it would be lovely to hear from other parts of Africa to expand on that and to continue that collaboration, and even going a little bit west to the Americas. Anyone that's interested to contact us. We do understand, we do speak English, and we will
Very good.
respond. And always happy to collaborate. Thank you, Alicia, and thank you again, Kevin, for spending time today.
And I'll just echo Nicolette's thanks. It's been so much fun. It's been incredible to hear both of your global perspectives. I think the collaboration amongst the PEDS-ID community is just the best part of our field, which I, again, am biased and feel like it's the best field. So if folks are listening and want to get more involved, I think the World Society of Pediatric Infectious Disease, if you're in Europe, the European Society of Pediatric Infectious Disease, if you're in the US, PIDS or the Pediatric Infectious Disease Society, great societies to join as a student, as a resident. If you have interest, come to a meeting, come to the WSPID meeting, come to ECMID, come to ID Week, come to the PIDS St. Jude meeting. We're a wonderful community. It's a fascinating field. And it's just wonderful to have colleagues like Alicia and Nicolette to talk like this about my work. Mostly I'm on Twitter or X, whatever it's called now, and LinkedIn. And the Premise project is my main project right now, which is a pandemic response immunologic repository. And we're hopeful to get some papers out soon, kind of looking at the patterns of respiratory diseases and how they've reemerged post-pandemic. So keep an eye on that space, and look forward to hearing what Nicolette and Alicia are up to, and hopefully we can reconnect sometime again soon.
Yeah, I certainly hope so, Kevin. And it's been wonderful. And it's been really, really my pleasure to have you both in the podcast.
That sounded like a fantastic discussion. There was obviously a lot of passion, and you could tell how excited everyone was. How did you feel that went?
So one thing that I wanted to remark about what Kevin said is that for most pandemic, even though we are looking for red flags or special announcements coming from the CDC or the WHO, most of the time it's going to be one physician, one of us, any of us, giving alert about something peculiar or something that we think is not the usual presentation of a disease. And then in the case of Nicolette, I think that she goes back to the principles of being a good clinician, trying to ask the right questions, and then go down to your differential and try to make the best use of the resources you have. And of course, it was very obvious to me that they are both happy working in infectious diseases. I think that there's a concern globally that there's a lot of people that is not getting enough persons interested in the field. And I think at the end we wanted to get people interested and involved and enthusiastic about infectious diseases, which I think that is a passion that you and I also share.
Absolutely. I think the other thing that obviously is quite interesting is that Kevin and Nicolette both work in very different healthcare settings and contexts, and like what a great and interesting comparison and great discussion about future health threats. For more information on future health threats and syndromic testing, visit the global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insights.
And that's the end of today's episode. We wanted to thank our esteemed guests, Professor Nicolette Duplessis and Dr. Kevin Messacar, for their panel discussion on the topic. We hope you have a deeper understanding of how syndromic testing can play an important role in anticipating future health threats.
Whether you're on your way to or from work, out for some daily exercise, or doing the school pickup, thank you for listening to the Syndromic Insights podcast. Make sure you're subscribed on your favourite podcast platform so you don't miss an episode. Please share the podcast with your colleagues, leave us a review, and be sure to tune in next time.